Good evening, everybody. Thank you for joining us tonight for SAMBA COVID-19 webinar series. Tonight is number 7, titled Tips and Pitfalls to Resuming Care at Your ASC, as well as Office-Based Anesthesia. As always, we'll start with the legal disclaimer from SAMBA. And as you read that, I would like to go over a couple of housekeeping points. Please note that in the right upper hand corner of your screen, you'll see a control box. There are 2 things in there that you need to know about, the chat box and the question box. So if you have any comments or if you have any technical difficulty with the webinar, please write it down in the chat box. Our staff will be monitoring that and they will take care of it and address it right away for you. The question box, I would encourage you to write your questions submitted throughout the webinar, and at the end we'll have an ample opportunity for questions and answers, as always with our speakers and panelists. So I have a little announcement to make. Tonight is the one before last of the SAMBA COVID-19 webinar series. The last one will be incorporated into our virtual annual conference. As you all know, we canceled our in-person meeting because of COVID-19 associated travel ban. So now we're going to have a true virtual experience in June 6th and 7th. Please join us. We'll have the last COVID-19 webinar incorporated into that meeting. We will continue, however, with other webinars around that time. We'll take the next weekend off. Everybody deserves a weekend off for the holiday, to observe the holiday with your families. And after that, we'll resume webinars in standard format. If anything comes up regarding COVID-19, we'll be happy to address that in another and separate webinar. So this year is our 35th anniversary, so 35 years of SAMBA. And for that, we're offering a special discount. Please check your email after this webinar to get the special discount code for our annual meeting, which is this year. It's a true virtual experience. If you haven't had a chance to visit our website, sambahq.org, we have launched your COVID-19 resources page. Lots of resources out there, lots of links that you hopefully will find very helpful. Among things they will find there under the webinar tab is this webinar series. All the prior webinars have been recorded and posted there, not just the video, but also the slides where you can enjoy and review, and you can share with your friends and colleagues. And tonight's webinar will also be posted after we recorded tonight. Over there, also under this tab, you'll see SAMBA statements. So far, we've issued 3. The first one was on March 17th regarding the ambulatory elective surgery, when we postponed those because of the pandemic. And then when we start providing that service again, we issued the resuming ambulatory anesthesia care statement. And last but not least, we issued the COVID-19 testing guidance before ambulatory anesthesia. And coming soon to you will be issued momentarily, probably tomorrow, is this checklist that your board have been working on. And I just got the last vote a few minutes before this webinar, so just got approved by our board, which is a SAMBA checklist for COVID-safe ambulatory surgical facilities. We will post that there for you to review and hopefully we'll use. And there will also be a little printout that you can add your facility name and saying that you are following SAMBA checklist for COVID safe ambulatory surgical facility. We're hoping that by this checklist is that we can help you to do the right thing and also assure your staff that you're working with that you are doing the right thing, and hopefully with your patients as well. When they know that you're doing that, then we ask you to probably share that with them as you communicate with your patient that you are following this COVID-19 safe ambulatory surgical facility list from SAMBA to kind of gain the public confidence in coming to our facilities to receive the care that they need. If all that is not enough from Samba. I wanted to share with you some of the benefits that we have always had: the annual meeting, deep member discount, discussion forums that we posted on the COVID-19 resource, the education webinar series, the research award, and opportunity to win a research grant as well. Chance for professional development and leadership opportunities. Many of our members were able, through their work with Samba, to advance their academic career. Networking opportunities unprecedented in other society, where you can mingle and get to know and become friends with the leaders in the field, nationally and internationally. And also we have the distinguished Samba Fellow status that you can achieve by participating in Samba activities and volunteering and so forth. There are certain criteria, obviously, that you have to meet, but it should not be a big deal at all if you join us and be part of the society. So if we're able to entice you and you'd like to join us, here's the website, sambahq.org. Click on Join Samba, and you can review these benefits one more time, and we'd love to have you there with us as well. And I just, speaking of membership, we have announced this year new ASC group discount membership. So if you are part of a small ASC and you want to have the whole team join us, if you have 2 or 3 anesthesiologists, if your pharmacist want to join us, your quality director, your nurse manager, you can always join us in a group discount membership from your ASC, and that's also available to you. If you log into our website, you will see that right there. Well, enough with the announcement and so forth. Now we'll get back to tonight's webinar number 7, tips and pitfalls to resuming care at your ASC and office-based anesthesia. As always, I've lined up a lot of great speakers, experts who will be discussing with us tonight their experiences in reopening their ASC as well as the office-based anesthesia practice. Tonight with us, Dr. John George, MD, Regional Anesthesiology Medical Director at Marymount ASC with Cleveland Clinic. We also have Gail Carrero, BSN, RN, CNOR, Nurse Manager at Marymount ASC with Cleveland Clinic. James Rosnack, MD, Orthopedic Surgeon. He's Surgical Director of Marymount ASC in Cleveland Clinic as well. And last but definitely not least is Megan Tatel, MD. She is the Medical Director of Mobile Anesthesiologist out of Chicago, Illinois. She will be the one talking about OBA anesthesia. And yours truly will be moderating tonight's session. I'll be delighted to receive your questions if you post those in the question box, and we will be happy to answer those towards the end. Well, thanks again for joining us. We'll start with our first speaker, Dr. John George. Would you please take your slides? Again, Dr. John George is an anesthesiologist. He is the Anesthesiology Medical Director of Marymount ASC in Cleveland, Ohio, with Cleveland Clinic Health System. He is a colleague of mine working in the same institution. John, thanks for joining us and agreeing to give this presentation. We do not see your slides up yet. We got it now. Thank you.
You're welcome. Bassam, thank you for the great introduction. And everyone listening, thank you for the opportunity for us to share with you some of our experiences that we've encountered so far as we've gone through this journey of trying to reopen in lieu of all that's been going on with this pandemic. I thought I would start off by talking a little bit about the model of our ASC. The 3 of us that are on the line, all work together at a freestanding surgery center within the Cleveland Clinic system. Our facility is freestanding, but we're affiliated with a nearby hospital, which allows us to transfer patients there and share some resources to some extent. Our surgery center is an orthocentric surgery center. We do roughly 3,300 plus cases a year, most of those being orthopedic, in addition to plastic surgery cases, podiatry cases, ophthalmology cases, and in the past we've done some ENT cases. As I mentioned, our surgery center is affiliated with one of the hospitals within the Cleveland Clinic system, And because of that, it allows us to share staffing with them loosely under normal circumstances. As a result of the whole COVID pandemic, though, many of our staff were relocated to the hospital to help out with flow of patient care in that environment. And so, like many of you, our facility was shut down pretty precipitously. Most of our staff were placed in positions within the hospital. Additionally, a lot of our supplies and equipment were taken to the hospital as well, probably similar to some of you in your facilities also. So from an anesthesia standpoint, that meant many of our glide scopes or airway equipment were taken away. Many of our ultrasounds that we typically use for nerve blocks were taken away for use in the ICU and in the operating rooms within the hospital system. We had the luxury of not having any of our anesthesia machines taken away, but I imagine for some of you that may not be the case. And that was one of the things that we had to negotiate and figure out when it came time to reopen. So as I mentioned, one of the first things we did as a group in terms of our leadership was to come together to figure out the best way we could reopen to make things safe for our patients and safe for our caregivers that worked here. The three of us met to talk about what patient care and patient flow would look like. One of the things we tried to tackle was the issue on mandatory testing or not mandatory testing of patients. One of the other things that we talked about was what things would look like for families and their patients as they entered into our setting. Would families be allowed to come in? How many of those family members would be allowed to come in? Would they be allowed solely just to drop their family members off or stay in our waiting room? Or should we send them back out to their car or their homes until we're ready for them to come back and pick up their loved one? As I mentioned, one of the things that concerned us from an anesthesia standpoint was making sure a lot of our equipment that had gone to the hospital had come back. So we did multiple rounds, multiple walkthroughs during those first couple of days of figuring out how we would best restart things by looking to see where things were and making sure things had come back. One of the other things that we did from an anesthesia standpoint was take an assessment of our supplies. As for many of you, we were closed for a few weeks, and during that time frame, some of our supplies not only was taken to the hospital, but some of those supplies actually expired. And if you guys are like us, our regulatory bodies are always looking to make sure that we stay abreast of where we are in terms of our supply and demand. And then the last thing we did was create a mock survey that we used to mimic what our Ohio Department of Health would use to assess whether or not we were actually ready to reopen. One of the mandates that our governor instituted in talking about surgery centers reopening was that we had to be ready for an impromptu visit from the Department of Health to make sure that we were able to care for our patients in a manner consistent with how we were caring for them prior to this whole pandemic. So some of our perioperative considerations that I thought were important to talk about in this webinar, again, were regarding family members. So we as a group decided that we would try to limit the number of family members that came into our facility. But as you can imagine, there are a lot of things that happen in the preoperative area where we need a family member present. So some of the pitfalls that we discovered as we reopened with this limited amount of family members that came in were younger family members or younger patients that came in without their loved ones. So you can imagine an 18-year-old coming for surgery a few months earlier when he or she was 17, probably would not have been able to even sign for a flu shot themselves. But now at 18, in this environment, we're asking them to not only be by themselves, but also consent for their own surgery and their own procedures. And that in and of itself created a lot of angst, not just for the patient, but also our staff as well. We also had people in our facility who came by with special challenges, such as a deaf person came in, and how do you communicate with someone via mask that may have a hard time hearing and reading your lips in normal circumstances? So those kind of situations were ones that we had to figure out on the fly as we went along in lieu of the constrictive family member policy that we instituted prior to reopening things. How did things look for us in terms of doing procedures like nerve blocks or breathing treatment? All those things we had to discuss up front. Nerve blocks weren't so much of an issue. We still maintained sterility as we would during prior to COVID circumstances. But breathing treatments were one things that we had to figure out, how do we do? How do we care for those people who may be dispersing droplets and breathing around other patients in the recovery room? Those are things that we had to tackle and figure out ways to tackle those without contaminating ourselves and our other patient population. One of the things that anesthesia in general had to tackle was figuring out how the OR process would look, specifically in terms of intubating and extubating patients. Were we to encounter patients who did not have a COVID test and tested negative, what would intubating those patients look like? Who would be allowed to be in the room and stay in the room? How would we protect ourselves in lieu of the limited PPE that's available not only in our facility but throughout the country? We as a group decided that most, if not all, of our patients that came through here would be required to have COVID tests. We had a luxury where we can do that at our facility, which simplified some of our process of being able to figure out how we would do things in an operating room setting. One of the other issues that came up from an anesthesia standpoint was trying to figure out if our supplies of medicines would be adequate or not. As you can imagine, a lot of our propofol supplies were used in the hospital, both for our patients who were COVID positive on the ventilator, as well as patients who came into the hospital for non-COVID related illnesses. And talk of shortages of various medications like propofol were considerations that we had to tackle and handle before we ensured that we would be ready to open and practice safely for our patients. And then the last thing that we talked about was, how do we manage our PPE? How do we become better stewards of those equipment that protect us? And do we even need to use those in our setting in the outpatient world? So if I can give you some of my final thoughts on things to think about and to consider when you're thinking about reopening, I think the thing that helped us most was our team approach to planning. In our group, we got our nurse manager, whom you'll hear from pretty soon. We got our surgical director, whom you'll hear from pretty soon as well as myself, to come together to talk about a plan that we wanted to have to take care of our patients and our caregivers. And that was the first step that we did, and I would actually recommend all of you to do the same thing as well. Things could not go further without being one unified body in that regard. And then the other thing that was helpful for us was starting slowly. It was very tempting for us to try to go back to doing things as we did prior to the whole COVID pandemic, but we as a group decided we would start slowly. So our footprint is built around 5 ORs that we consistently run on any given day. We scaled that back to 2 ORs, just to allow us time to be able to figure out if the model we had in place to allow patients to come, if our staffing model was correct, so that we wouldn't progress too quickly and risk the health and concern of our patients. And then the last thing I wanted to mention that was important for us was just being flexible. As I mentioned, our plans that we started up front changed throughout the process, and being able to be nimble and adjustable was one of the things that helped us manage in those first few days, if not weeks, of getting back up to full speed. Thank you.
Thank you very much, John. We appreciate your thoughts on this. And next we'll be hearing from Jim Rosnick, who's the surgical director of the Marymount ASC. Jim?
Just taking myself off mute, and I'm sorry, my webcam is not working. So you can probably just leave up John's last slide if you like, or Gail's first slide, Basim. So thank you all for including me in this. As you heard from John, who very eloquently kind of described our process. You know, from the surgical side of this, you know, the keys for all of us were some of the points that you already heard. Really, number one, safety. I think, you know, this time of uncertainty for everybody induces a lot of fear. You know, as you heard, we do a lot of orthopedics at our ASC, and people want to get their joints fixed and they want to get back to being active. But you know, with everything that's been going on, we wanted to provide a safe environment for the patient, number one, But I think a thing that we all shouldn't overlook is a lot of caregiver anxiety as well around this too. So I think the combination of both of those things really drove us to demand preoperative testing on all patients within 3 days of surgery, which of course our institution supported. Other things, just kind of from the surgical perspective to reiterate, we're a training institution, and we decided that instead of, for some cases which are maybe unique or a higher level of acuity, where you may have a fellow and a couple residents because it's an interesting case, we decided to try and limit that to one trainee per case when possible. There's obviously situations where an extra set of hands is needed, but again, just try to control what you can, limit the exposures that you can, when possible, recognizing that that's not always feasible. Another thing that's pervasive within our ASC is the amount of device representatives that are around. And as you kind of heard from John, our footprint isn't huge. And what would end up happening is, people would end up hanging out in the break room, and that's not a huge space. So if we're trying to maintain appropriate social distancing, we really put a limit on the amount of reps available, recognizing there are obviously times when they needed to be present for help during the procedure, which of course would be okay, but no more than one in a room, and really just to kind of be there when asked instead of just showing up like they would normally. Something that's changed for us from the surgical side of it too is the post-op flow of things. Generally we would go out, myself and my partners would go out and discuss face-to-face the operative pictures, or if there weren't pictures, just talk to the families about how the case went. And we decided that given the small area that we had for a waiting room and the limited number of seats available, we recommended patients go sit in their car or go home, actually, if they're within a half an hour or so, if that was possible. Again, just to limit as much as possible the violations of the social distancing, recognizing that it's not a perfect science, but just giving people the opportunity to stay safe and feel safe, most importantly. And then I think the last, not to beat the horse here, but in terms of the three of our communication, I'm so proud of that, and I think that has been something that really helped this process, not bumping the road free, but it's made it as smooth as possible. And I think from the surgeon perspective too, I really tried to over communicate with my partners because of the uncertainty and basically being shut down for 2 months, and really just tried to give them an open window into what we were thinking, what we're hearing from the administration, and just so they understood the thought process. And that included only opening up 2 rooms and who was going to get those 2 rooms. And you can imagine that those were some conversations that we felt very important, or we felt were very important to enter into this in a slow manner. And everybody understands that, even though they want to get going, they want to get moving. This is unprecedented times, and people were very willing to listen and be understanding in this scenario. So, proud to say we're back up and running full bore now, and I think Gail and John would all agree that people feel safe when they come to our facility, which with all this good that's going on, that's the environment we wanted to provide for everybody.
Thank you very much, Jim. Appreciate your comments and insights. We appreciate that. And now we'll be followed by the third member of the multidisciplinary team that reopened this freestanding ASC. Gail Carrero is the nurse manager within that facility, who works very closely with John and Jim. Gail, can you please take the screen and slides?
Thank you. Good evening, everyone. I just want to say thank you for this opportunity for us to be able to share our story. And some of you may have similar environments or situations as we did. and our hope is that you're able to learn from our experiences and also expand upon them. So this is a great representation of how we felt when we were introduced to this invisible, vile monster named COVID. And on March 19th was our last surgical day before our shutdown here at our ambulatory surgery center. We really didn't have time to prepare or had the ability for a proper shutdown, because on March 20th, the very next day, our entire ASC staff was deployed over to our hospital, which is 3 miles away from our building that we're in. That hospital was the first COVID site of our system, and they were planning for a surge, so they urgently needed the staffing. They were placed on nursing units in the emergency departments, in behavioral health, ICU. Our surgical techs were trained to become PCNAs, and our RNs were upskilled to be able to independently take care of patients on floors. At first, we were told that the prediction was that we would not return to surgery until June 15th. Now, as mentioned, our equipment was deployed between the hospital to help prepare for that surge, and the rest of it was used within the building as the sports health clinic was turned into an orthopedic acute care center within the building. And their plan was to be able to divert healthy orthopedic patients from the busy emergency rooms that were taking care of COVID patients. Now we'll fast forward to the end of April, when we were able to feel some hope and some excitement as we were selected to be one of the first ASCs of our system to be able to return to elective surgeries. And since we were off-site, we knew that we would not have the support of the departments as a hospital environment has. We pulled together as a team, and we were the resources that were able to make things happen, and we were the ones that had to invite other caregivers to help us to make sure that everything was going as planned. Part of that list included reaching out to the maintenance company that takes care of this building, especially while we were gone, to make sure that temperatures, humidities, and air exchanges that are necessary in ORs were at proper levels when we returned. That's when we learned that we had a little bit of a setback with our oxygen and our lines. We also invited infection prevention, emergency service, the manager of environmental services, materials management, and pharmacy to help us go through our checklist and make sure everything was returning to normal. We discussed placing signage for patients as well as for our staff to be able to start practicing the social distancing that we had discussed. In this picture, you're looking at our registration desk. To the left, where that far left black carpet is where our elevator empties out onto our second floor. You can see that there's tape along 6 feet away from where our registration intake is, as well as there's squares that were placed for patients to be able to know where to stand. As we mentioned, we didn't let visitors into the building unless it was a minor or a patient that was in need of assistance. What we were originally told is that whatever our occupancy permit of the building should be approximately 50%, and not only for our department here up on the second floor, but we had to take into account that the first floor also had occupants as well. So as we mentioned, our visitors were either waiting in the car or they were encouraged to go home. Now, those that were with minors or with patients that needed assistance, those people were able to go into the pre-op area with them, but as soon as they left for the operating room, they were expected to leave the building. Our waiting room, you could see that some of the chairs had been turned around to face the wall to prevent people from sitting in those areas. Also, there were a number of chairs that were removed from the area. We have only 7 available seats, and they're only used really if there's just a few moments where a patient is waiting just prior to be taken back to our pre-op areas. The locker rooms is another consideration that you're going to need for your social distancing. You could see that this area is less than 6 foot wide, and we just had discussions with our staff to remind them that if they see too many people in the locker room, they leave, they wait outside until someone exits, and then they'll go in. And they were really receptive to that. They're in there, they're not chit-chatting too much because they know that there are other caregivers are waiting to change as well. On the left is our pre-op area, and you could see that we have glass doors with walled off bays. So there was no concern there for patients being too close. On our right is where we do our regional anesthesia blocks. And you can kind of see by the numbers on the ceilings, we actually use what was originally 2 bays. So you can see a 4 and a 5 up there on the ceiling. We've transitioned that to only putting 1 patient in that double spot. And people were pleased with that as well. We also have hush curtains, which also provides additional separation from patients. So there was no concern in that area. This is a picture of the inside of our elevator. It's not really huge, but we also put some standing squares just to remind people to stand back. The recommendation for our elevator is only 2 people on the elevator at a time. But again, that wasn't too much of a concern because family members were not traveling with the patients up to the 2nd floor. This is a picture of our lounge. You could see chairs have been removed, tables have been separated, just to remind everyone again about the social distancing, because in this area, of course, with the eating and drinking, they're not really wearing their masks. So when we had a return to service, there were other departments that we needed to reach out to as well. Security, that changed their hours to accommodate what was the acute care center. They didn't open until 10. We had to remind them that we were bringing patients and staff back to full service. So we needed someone again at the doors from 6 a.m. until 9 p.m. Our linen services, our scrubs were depleted because of the staff that remained here in the building for the acute care center that I mentioned. And we had to make sure that all of our linen was back to full par levels, especially our scrubs. Patient nutrition, some of it had been depleted while we were gone. We had to check out dates and integrity of packaging of the food. We brought our staff back from the nursing floors. They were able to do out dates. They cleaned and they cleared out clutter. They washed waiting rooms and equipment because our EVS staff had been deployed at the hospital and they had not yet returned. We also had to return the PPE that was once removed from our scrub sinks for fear that somebody would come into our department while we were gone and pillage through it. So that was locked up and we were able to return it back to scrub sinks and sites that they were before. Also, we had rumors that the State Board of Health would be doing inspections at ASC sites that were originally shut down during the COVID crisis. So we had accreditation people help us and do walkthroughs to make sure that we were ready. As I mentioned before, we had a holdup with a medical gas line, and we found out 2 business days prior to opening. We had to completely change our gears, and fortunately, we immediately reached out to the hospital that we were currently at, and because they had a late notice that they would be opening for elective procedures, we were able to secure 2 operating rooms over there every day for the week that we originally were supposed to return to our ambulatory surgery center. And the big one was our administrative staff gave the okay for the ASC staff to be able to work in the peri-op areas. That was a huge caregiver satisfier. The fear was that they were going to let the OR staff from the hospital do the cases that should have been ASC cases. So like I said, huge satisfier for not only the ASC staff, but also for our surgeons and their surgical staff who hadn't seen us in about 7 weeks. When we were able to return to surgery, one thing that you do want to remember is you got to remind staff they have been away for a number of weeks. You have to remember that we are still continuing our safety practices such as universal protocols, timeouts. We still maintain our counts and our fire safety. We had to remember that for us, we're encouraged and expected to wear cloth masks when we're walking through our building. And it's easy to remember that you've got that mask on, but you forget it's a cloth one, and that's not approved for OR settings. So we had a buddy watch just to remind each other that we had to swap out our masks. Our first day back at our surgery center went very well. We did 10 cases, and we only ran 2 ORs. As we mentioned, we did a soft opening. The registration was no problems whatsoever. In our pre-op, we had started dabbling a little bit with, we had in our electronic medical record, we had the ability to be able to text families. And because we have such a small area, we really didn't use it too much, but staff was encouraged to start using it a little bit. When we returned from COVID, we found it very important because family members had no idea. They let that patient get dropped off at the door, and they had no idea. So we made sure that we were texting families just to let them know that they were in the surgical area. Our surgeons were calling family when the procedure was done just to let them know what happened. And then we were again texting families to let them know that their loved one was in the PACU, and we were going to be ready to have them ready for discharge. I think the biggest change for us was in our PACU workflow because of our homegoing instructions. Normally we have family at bedside that we can review medications, we can review dressings, and review braces and how to put them on, or pain pumps, or cooling devices. And it's very difficult to do that over the phone. So the options were the phone instructions, curbside directions. As we're putting the patients into the car, we would review things with family at the car, or we have consultation rooms that were no longer being used by our surgeons since they were making phone calls. And we would bring up parents into those consultation rooms and have the patient and then the nurse review discharge instructions there. I just wanted to say, I hope that the takeaways you have here are really understanding that it takes a team, definitely. And there is a quote out there that mentions that it possibly takes a village to raise a child, but I'm here to tell you that it definitely takes a similar group to be able to open an ASC. I just want to say thank you for your time.
Thank you very much, Gail. Isn't it the truth? It shows that the teamwork is important, and you guys exemplify this teamwork. We'll move on now to the office-based anesthesia, and we are grateful to have Dr. Megan Tatel from Chicago, Illinois, who has her own mobile anesthesia office-based practice. Who's going to share with us her experience and words of wisdom. Megan?
Thank you,
I
Boss.
think you're muted. Yeah,
I think I should be set. I'm so happy to have the opportunity to be here tonight. Thank you, Dr. Schweitzer and Samba, for the invitation to speak this evening. For the last 7 years, I've been doing office-based anesthesia with mobile anesthesiologists of Chicago. And for the last 3 years, I've acted as medical director of our practice. I have no disclosures to be made, but I do work for a practice that does all ambulatory anesthesia. And so I may be a little biased about what an important service it is for patients and proceduralists. And just a disclaimer though, the practices described in the presentation are based largely on CDC, CMS, and large national society guidelines, but are also heavily influenced by requirements of the Illinois Department of Public Health where I practice, and they may not be applicable outside the state of Illinois. As we all know, with many society statements, ongoing webinar series, there's a huge volume of information to address in regards to the novel coronavirus and healthcare and ambulatory anesthesia specifically. I'm going to focus my discussion on the impact COVID-19 has had on ambulatory anesthesia and how my group has been able to continue to safely provide anesthesia services for time-sensitive cases, the best practices we have put in place for resumption of routine and elective cases, and I'd also like to start you thinking about what the long-term ramifications of these healthcare changes may mean to office-based anesthesia. A little background about my group for reference. Mobile was started over 23 years ago by an anesthesiologist, Dr. David Barinholtz in Chicago, Illinois. After surgeons at the hospital approached the anesthesia department to do their cases, when the department couldn't make it work, he saw a niche and started Mobile with the help and support of several of his colleagues. One unique feature of our practice is that at each site, not only do we provide the anesthesiologist and everything they need, a nurse comes along as well as part of the team, which means you always have someone with you whose skill set you can depend on in an emergency. We have a long track record of safety with no malpractice claims in the last 15 years, and we have participated in over 275,000 cases in that time. You can see here the variety of specialties and locations that are serviced by Mobile. Chicago is the foundational location, and it's still the largest practice. This data is a few years old, but it's the most current I could locate. And as you can see, as of this time, The total annual surgical volume in the US was 56.5 million, and the breakdown was 23 million ASC procedures, 12 million office-based procedures, 11.5 million hospital-based ambulatory procedures, and 10 million inpatient overnight stay hospital procedures. Additionally, healthcare consultants anticipate that approximately half of current outpatient hospital procedures can, and thus most likely will, be moved to the ASC or office-based setting over the next 10 years. This is because in addition to saving time with the shorter turnover time, 1/3 to 1/2 of that in hospital settings, and patient full check-in to discharge time being less than half in an office setting versus a hospital, they also save money. In-office procedures on average cost 1/3 of the cost of taking a patient to the hospital for the same procedure, and some of these cost savings are transferred to the patient. Although office-based anesthesia has been compared to the Wild West of anesthesia, as with all patient care, safety is our priority. And office-based anesthesia faces unique challenges in this realm. Scarcity of personnel means there's no blue button to press for emergencies. The anesthesiologist, and in our case, the nurse, are ACLS trained, but maybe no one else on site is. Your ultimate backup plan is to call 911. In order to maintain the lower cost environment, not all equipment is there. For instance, there's no large variety of intubation aids. Often we have no anesthesia machine, no ventilator, limited monitors. There's no arterial lines or CVPs. And this is also true for surgical equipment. Particularly difficult right now is the lack of large hospital support for procurement, especially for PPE. Limited anesthetic modalities and emergency medications are on site, but no pharmacy for drips, etc. There's limited or no accessory services, so no blood bank, limited pathology. And because of the limited space, there's no option for prolonged recovery. Often a recovering patient must be gone before the next can be moved out of the procedure room. You have to address different room setups, beds, chairs, etc., that you wouldn't be used to seeing in the OR setting. And the standards of care, or what's bemoaned as often the lack thereof, are a concern. Although many cases are done in this setting, not all involve anesthesiologists. Many are done under oral or moderate IV sedation, and there's little published data and often vague guidelines. As we all know too well, there has been turmoil surrounding the appearance of the SARS-CoV-2 novel coronavirus in the US. On March 18th, CMS issued guidance that all non-essential procedures should be put on hold. And just this morning in her daily update, Dr. Marydale Peterson, the president of the ASA, mentioned that a survey of anesthesia administrator and executive members generated 133 responses representing more than 4,000 anesthesiologists. And over 90% of those respondents said their case volume had decreased by more than 50%. Most were at a 70 to 80% reduction in cases since the declaration of this national emergency. Most office-based procedures are not truly sterile environments. Think GI endoscopy. So very little PPE was used before the novel coronavirus. Clean scrubs and disposable gowns were the norm. So there's been a need to rapidly change plans, relearn donning and doffing, and acquire the necessary elements. Many suppliers, for instance, McKesson, who we do a lot of our purchasing through, are only allocating N95 respirators to groups who had a previous order from them. So not only is PPE scarce, but it's very difficult for small practices to source. Our staff of 21 anesthesiologists and 30 nurses provide services at nearly 50 clients in the Chicagoland area. And as we travel from office to office, we worry about being a possible source of infection and have altered our scheduling to try to cluster groups of staff to specific clients to minimize the exposure risk. Patient selection criteria also had to be readdressed to minimize risk to the healthcare team and our patients. And many of our clients are solo practitioners in small offices. They fear becoming ill or having a staff member fall ill and thus shutting down their office completely. So one of our chief concerns during this pandemic has been the safety of our staff. As of March 13, we asked staff to suspend all personal non-essential travel, and travel to any high-risk area that had occurred required a 14-day self-quarantine before they were allowed to return to work. For the IDPH guidelines for healthcare workers, a temperature above 100 Fahrenheit constituted a fever, and staff could not report to work if febrile or symptomatic. We asked staff to wear a face mask when presenting to client facilities, and one of our RNs completes a daily infection control audit specific to the SARS-CoV-2 virus, including checking staff temperatures on site, verifying equipment and room cleaning with solutions that are EPA approved for killing the coronavirus, and a proper use of PPE, including a respirator during aerosol cases in accordance with the ASA ASPF statement on PPE. Another critical element has been caring for our team outside of the clinical realm. I have to take the opportunity here to praise the amazing efforts of our administrative and executive leadership team for keeping our group intact to this point. They immediately jumped into action, securing PPE. They stayed on top of our opportunities to access funding through the CARES Act, including the PPP loan, which you know is capped at 100,000 salaries, so supplemental loans and lines of credit are also investigated. Webinars were hosted to keep staff apprised of the company state of affairs and resources available to them, including emergency paid FMLA for those with childcare. We were operating at a 15 to 20% of normal case volume, so we didn't have our normal clinical work available for the staff at their usual levels. Because many sites, when they did have cases, were very abbreviated days, 1 to 3 hours versus a normal 6 to 7 hour day, we started a 4 and then a 6 hour minimum pay for RNs. This did not apply to physicians because they were salaried and it wasn't necessary. But in order to maintain individual employee income, a decision was made by our group to allow use of up to 75% of the estimated annual PTO bank to supplement clinical work. And we also had opportunities for non-clinical work available. Physicians and nurses were asked to voluntarily take unpaid time if they could, and many of our staff stepped up and we really appreciated it. We also temporarily released all staff from non-competes to work in hospitals or take locum jobs if they were interested in doing so. And several of our nurses did pick up more ICU or emergency department shifts and travel assignments. We also offered bi-weekly coffee talk or just virtual meetings for staff to check in, vent frustrations, and connect with one another, as well as a structured mental health wellness webinar to help staff deal with the stresses that home isolation and radical change in work environments might be causing them. In keeping with the SAMHSA statement of April 18th on resuming ambulatory anesthesia care as our nation recovers from COVID-19, the CMS reopening facilities to provide non-emergent, non-COVID healthcare, and statements from GI and surgical societies, we have worked to minimize physical interactions at our facilities. Patients' arrival times are staggered, such that no two patients should arrive at the same time for check-in. Patients don't have to wait in the waiting room and are instead escorted to a care area. If there is an unexpected wait, the waiting room chairs have been rearranged or labeled to provide 6-foot distancing. No drivers and visitors are allowed in the facility. They wait in the car. Exceptions have been made for minors or patients requiring family member support. But in those cases, the family member must wear a mask and leave as soon as possible to return to the car. The proceduralist meets the patient direct in the procedure room. And after the case is done, the proceduralist calls out to the family with a report, and patients may also receive a report in recovery. Once a patient is recovered and dressed, they are then escorted by our nurse or assistant out to meet the driver in the parking lot. On March 13th, 5 days before the CMS statement calling for a stop to elective cases, we actually reached out to our clients ourselves to ask them to assess their upcoming cases and triage them as urgent or non-urgent. In office-based anesthesia, we don't really do emergent. For instance, think about colonoscopies for anemia or prior bad polyps versus a screening, or DNC for acute bleeding versus ablation for chronic menorrhagia. Once the CMS statement came out, we made the decision in conjunction with our clients to completely stop anesthesia for interventional pain cases, as the cases were not urgent, and if they were, they could be done without sedation. This was also the case for cosmetic plastic surgeries. In concordance with statements from the American Dental Association and the American Academy of Otolaryngology and Head and Neck Surgery, that these were the highest risk procedures, we stopped doing those in office completely. Emergency cases were sent to the hospital or done under local without anesthesia. At the time, pre-op calls, usually 7 days prior to a procedure, Patients were screened by phone with questions in keeping with the CDC recommendations, and any positive answers are addressed and the case is delayed if necessary to minimize risk. Patients were advised to call us if they had any answer change prior to the day of the procedure from their screening. And obtaining coronavirus testing has been very difficult for us. Our group has no hospital affiliation, and until very recently in the state of Illinois, commercial and public health testing centers would only test symptomatic patients, which our screening process was screening out. Testing of all patients was just an impossibility. And as such, the risk of delaying these cases and having the patient put at risk to their health or winding up in an emergency room was balanced against the risk of them being an asymptomatic but infected person. So in the absence of testing, all patients were assumed to be potential carriers and all precautions were taken against that. Screening was repeated on admission on the day of the procedure and a temperature check before the normal admission process. This was in accordance with the SAMHSA statements of April 18th and April 30th to test if at all feasible. And any patient who arrived without a face covering was given a disposable face mask to wear throughout the stay. And our staff wore PPE appropriate to the presumption that all patients could be carriers. For elective cases, the rules change a bit. These cases also undergo a 7-day pre-op interview and phone screen in accordance with the ASA APSF statement for an area of local or regional presence of COVID-19 and per the Illinois Department of Public Health. All elective procedures must undergo novel coronavirus PCR testing, and then the patients self-isolate until the time of the procedure. This has been our major hurdle. I'm proud to say that through the diligent efforts of our CEO and CCO, we have established a relationship with LabCorp that allows us to offer our patients pre-procedure PCR testing via anterior nasal swabs. The great part of this test is that it's more predictable to obtain a sufficient sample as it doesn't require a near brain biopsy like a nasopharyngeal swab. And the swab is transported to the lab in saline, not viral transport media, so it doesn't have the bottleneck of that limited supply. LabCorp estimated for us a 48 to 96 hour turnaround, with most being in under 48 hours. However, as we begin testing, although it's outside the recommended 72 hours, we are starting with a 4 to 5 day lead for testing in advance and still asking patients to self-isolate during that time. Like so many other parts of this crisis, we have to understand our limitations. We test the waters and we adjust from there. If we are consistently getting tests back within the 48 to 72 hour time frame, we'll move up our testing to match that. And despite testing, we do repeat the screening questions on the day of the procedure along with the temp check. Patients will wear masks on admission and all of our staff continue with the full PPE. In our area, there is some degree of community spread. So when we're looking at our screening questions, these travel items become less relevant. Our screening is for symptoms and direct exposure as recommended by the CDC, and the list of symptoms comes direct from the CDC website. The final question here about practicing social distancing and only leaving your house for essential needs is more of a fact-finding one. We added it in there to have some semblance of the overall community exposure of the patient, and it can sway our decision to test patients even for time-sensitive cases or to transfer their care to the hospital. A positive screening is reviewed by a doctor and discussed with the client physicians. And healthcare workers who have cared for COVID-19 patients but have been wearing proper PPE can still have their procedures done. But we've decided to move these cases to the last case of the day or give an extra 30-minute turnover time between cases to protect any patients that would follow them in the procedure room. So what to do if a patient does test positive when they have the PCR test? If they have symptoms, when we call to give them results, we refer them for an appropriate level of care. Ideally, our screening removes all symptomatic patients. And so many resources, including the ASA, APSF perioperative testing guidelines, give only the conditions for someone who tests positive but had symptoms. Therefore, they say 72 hours without fever. However, since our patients should have been asymptomatic, being fever-free for 72 hours is meaningless to us. Presented here, you see the conditions which are listed by the CDC for stopping quarantine on those who never developed symptoms, but had a positive PCR test. So being ready to leave home and likely no longer contagious doesn't necessarily mean that they're ready for anesthesia. As such, you have to consider how extensive the surgery, the type of anesthesia planned, as well as the patient's exercise capacity and overall state of health when you're assessing the risks and benefits for the timing of their procedure. In office-based anesthesia, we already have a very regimented patient selection criteria to reduce the risk of emergency hospital transfer. We've added some additional criteria that will trigger review by an anesthesiologist and a discussion with the proceduralist. The BMI and weight limits were added to minimize the likelihood of emergent airway manipulation. The age items are there to select out the patients who are most at risk for poor outcomes if they were to contract COVID. So we chose this age over 60 with active comorbidities, things like COPD, long history of smoking, coronary disease with active symptoms, and all patients over the age of 70. But if the procedures are of a time-sensitive nature, we balance the fact that the ASC or office setting may actually be a safer option than sending them to the hospital in terms of concern for possible disease transmission to these patients. We've also encouraged open and active communication with our surgeons and proceduralists always, but even more so during this pandemic crisis. We can make whatever plans we like to protect our patients and staff, but if our clients are not in sync with us, it's a moot point. We have shared with clients our best practice plans for case selection, urgent and moving toward elective in the upcoming days and weeks, new patient selection concerns. We've explained that we expect them to match us in the level of PPE provided to their staff and their safety protocols regarding visitors and masks for patients. The most recent focus of the discussion has been testing and timing and requirements. Sites that cannot or will not test all their patients, mostly due to inability, patient hassle, and the high cancellation rates that we're seeing, cannot move to the phase of elective cases, both per our group's decision and per the Illinois Department of Public Health requirements for elective cases. So again, please do look to your state Department of Public Health for guidance. We have also been making sure that we have the same expectations like increased turnover time for proper cleaning, donning, and doffing of PPE. To ensure consistent standards and communications with each client, we developed a facility checklist that can be used during our conversations with the clients as they plan to resume cases at their facility. You see here the structure of that checklist. As you can see on this list, another way we've worked to solidify our client relationships and ensure safety of everyone is to offer to supply PPE when possible. As any of you who have been working in the purchasing chain know, it's been increasingly difficult to source PPE, and often gaining any foothold requires a large minimum order quantity. Because we're a small group and many of our clients are even smaller, we bought some items in bulk, including respirators, and are offered them to our clients essentially at cost when possible. This infographic from the CDC demonstrates their recommendations for PPE, and this meets the ASA ASPF recommendations. It includes a hair color, cover, face shield or goggles, an N95 or equivalent respirator for all aerosol generating procedures. And I want to note here that the CDC does not have a consensus statement on what constitutes an aerosol generating procedure, but the ASA stated that this would include tracheal intubation and extubation, manual ventilation, non-invasive ventilation like BiPAP or CPAP, bronchoscopy, open suctioning of airways, sputum induction, and CPR. They also say that surgical societies, including the ACS, cite procedures that are potentially aerosol generating to include upper airway and skull-based procedures and upper and lower GI endoscopies and laparoscopies. Other PPE includes the gowns and gloves. One other option not shown because it's not required by the CDC guidance is shoe covers. Basically, we are caring for all presumptive negative patients. And as such, we're allowing extended use of the head cover, face shield, and respirator or mask unless it's visibly soiled. And any single patient use only for gowns and gloves, more to protect patients from patient-to-patient transmission. We also had a clever doctor of ours recommend placing our tablets, which we use for our EMR training, into Ziploc gallon bags. They're much easier to wipe clean than the Surface tablet itself between patients, and we dispose of those daily. In summary, communication with your surgeons and proceduralists open. Rely on them to stay abreast of the recommendations of their national societies as you stay on top of the recommendations of the American Society for Anesthesiologists and SAMBA. Look to their clinical judgment as to the urgency of timing for cases. Follow and actively engage your local and state health departments about the differences in ambulatory settings, and make sure that their safety expectations include your settings and address your needs. Try not to get bogged down by the fact that today's requirements will change tomorrow. And before this pandemic, the trajectory was already strongly showing a move for ambulatory procedures out of hospitals and into the ASC and office settings. There's good reason to believe that this health crisis will accelerate and accentuate that move. Data already showed that patients tout the office-based setting for increased comfort and a lower risk of nosocomial infection. And if you aren't going to a hospital full of sick people, it stands to reason that you aren't going to be much at risk of getting those infections. And I think the pandemic will likely have a strong impact on that decision process for patients. Thank you again for your time.
Thank you very much, Dr. Taylor, for this very informative presentation. We appreciate that. A nice section of our membership are in the office-based anesthesia sphere, and we're happy that we're able to provide some guidance to them tonight. We appreciate that. At this point, I would like to invite all our speakers and panelists to turn their videos and audio on, if possible, please, so as we can address some of the questions that we have received. And again, I would like to thank Dr. George, Dr. Rosnick, Ms. Carrero, and Dr. Taylor for the informative presentation that we received tonight. We appreciate that. The first question I received says, how are nebulizer treatments are performed in your facility? I think this is for Dr. John George, who talked about that. The question is, how are nebulizer treatments are performed in your facility?
Yeah, so it's difficult. Obviously, those patients can't wear masks when they're wearing our nebulizer. The way we worked it out was most of our PACU bays have curtains similar to the ones that you saw in our preoperative area for blocks. We close those to make sure that nothing goes outside or around those curtains. And additionally, all of our patients, at least at this point, are tested for the virus. So it's not 100% safe. I think our tests are roughly 2 to 3 days within the day of the procedure. So there's always a chance that a patient could be negative on the day that they get tested, and of course get an exposure at some point prior to coming in for their procedure or surgery. But within that 2 to 3 day window is how we test people, have them come in. And for those specific procedures that you mentioned, we close the curtains, keep them isolated to some extent. Our nurses do not wear N95 masks in that environment. We treat the patients as if they were negative based on the negative test. Of course, we all know that there is a potential risk for a false negative result and potential for turning positive, but that's currently how we handle things. I think, Bassem, you also deal with some bronchoscopy issues that may be similar in regards to this. You guys do anything differently from your standpoint?
Thank you very much. We do the same. In fact, actually, we try to, if there's no barrier between the beds in the recovery room, we keep a distance of 6 feet between patient and the other. Thank you for this insightful answer. I just wanted to clarify something regarding your ASC. I remember Gail talked about surveys and so forth. I just wanted to assure people that CMS and Joint Commission have suspended the survey since the declaration of the emergency state. However, the states are doing some surveys now regarding COVID readiness for ASCs. So that was kind of the survey that Gail was talking about. The other survey that also is not suspended and still can happen anytime is a patient complaint survey. If a patient complains the Department of Health of your state will be coming in to survey your facility. But the surveys that are going on right now are the COVID readiness survey. They are not the standard CMS or Joint Commission survey. The next question, it could go to anyone. It's probably Megan may have some more experience with it, which is a very interesting one and it's worth discussing. It says as follows: with all of the money practices are now spending on extra PPE to keep both patients and staff safe, are there any plans for insurance companies to provide additional reimbursement, or are there any other avenues to recoup some of what's being spent on these extra measures? Any thoughts on that?
That's a terrific question, and I would love to say that we're going to get reimbursed for it more. I do know that my billing team has been hard at work looking for additional codes that we could use to access any more funding from this, but at this point, there's nothing official that's come out saying that anyone's going to reimburse extra for all this extra equipment. It's just sort of getting absorbed into the cost of business, unfortunately.
And that was the next follow-up question to us. If not, do you anticipate providers and practices paying out of pocket for these expenses indefinitely as part of this new normal?
Yeah, I mean, like I said, unfortunately, at this point, there hasn't been any success in getting any of our payers to agree to pay extra, but our billing team is definitely experimenting with some codes and working with coders and trying to see if there's anything additional they can get. I would highly encourage you to speak with your billing team about trying to find ways to get some increased, recoup some of that increased cost that you're having for patient safety.
Thank you. I did hear, I was watching TV the other night and I saw a segment regarding restaurants' COVID surcharge. And they were talking about, I think, 3% of the bill or something like that. We'll see if we end up going that route, but it is a concern. And because, as you all know, we're spending quite a bit of money, and some of these masks and stuff prices have gone up because of the demand and the competition of acquisition. So it is a major concern, and it adds up. It's a few dollars here and there. It adds up at the end of the day for the cost of care at the facility. The next question says, we are well underway to resuming doing office-based anesthesia in a local plastic surgery office. The office has not instituted COVID testing on our elective cases, but they are looking at doing it based on our recommendation as well as their accreditation organization. If patient test negative, are there recommendations for waiting a certain amount of time after airway manipulation at beginning and at the end of cases for room air turnover, or are people foregoing this in light of the negative COVID test?
So I think, the information I've seen on this mostly was based on an ASA FAQ about this that you can find on the ASA website. But if the patient tests negative and all of your providers who are in the area where the patient had the airway manipulation are wearing respirators, then you do not have to have extended period of time. At this point, the ASA is still recommending treating all patients who tested negative as still a possible false negative, a possible infected person, a possible asymptomatic infected person. And so they do recommend that if an aerosol generating procedure, including intubation or extubation, occurs, that everyone present should have on N95s, or that you should wait for that room air exchange cycle time, which is on average about 20 to 30 minutes before you have those people present in the procedure room. So I would say, even if they test negative, you should be wearing N95s per the ASA Anesthesia Patient Safety Foundation statement. And if everyone has an N95, you don't have to wait for that time.
Thank you very much. Again, for for this member, if you go back to last webinar, you will find some extensive, detailed responses from our speakers then regarding this question of room air turnover. And there's also a posting on our forum that addresses this question. Obviously, the test negative, as we discussed before, is at a point of time. Whenever that test was done, that patient was negative. At that point, there is the patient carries the risk of the false negative, which in some good tests is only like 2-3%, some not so good tests up to 30%. And then the issue of the fact that they might get exposed after that point of testing till they show up for surgery, and that's why our statement says instruct patient for self-isolation till they get to you, because they might been exposed, and that's why we do a secondary screening or continuous screening till they show up for the surgery. And if they show up with no symptoms, that's when you accept them as a cancel, but you still consider them as asymptomatic carrier, as we've discussed before on multiple occasions. I want to ask also, Jim, what was the most, you found the most difficult, the most intriguing aspect of returning to function or returning to service in your ASC, please?
The most interesting or the most intriguing? I think he has two there. No.
That would be great. Comment on either.
I think it was the balance between everybody being more than ready to go full go and balancing that with the desire to just make it as safe as possible. And I think that everybody understands the need to, or understood the need to go slow, but I think it was in terms of intriguing, I was really comforted by how supportive everybody was from my partner's perspective, who, you know, maybe didn't get to operate that first week because, you know, there wasn't room because we were going slow. So I think that's what I would say was the most interesting for me, because, you know, I'll know we deal with a lot of personalities. So I was very comforted and encouraged by that.
Thank you very much. Gail, the question goes to you. What was the most difficult or the most interesting or most intriguing aspect of resuming care at your ASC that you want to share with us? Or even just a word of wisdom from experience that you had that you wish to share with the group, please.
Well, I'll tell you one thing that I did not think about, and it came to light, is some of our surgeons that had not been deployed anywhere else were concerned about working with caregivers that had been at a COVID hospital taking care of COVID patients. So just working together and, you know, basing everything off of what infection prevention was telling us. And, you know, there was some thought about having caregivers tested, but, you know, the standard practice was we would not be tested unless we were symptomatic. And I could tell you that out of 23 caregivers that were deployed over there, not one of us were sick. And like I said, a lot of them were in ICUs and EDs taking care of COVID patients. But, you know, just teamwork, like I said before, you know, just the way that we were all able to pull together and make this really happen. You know, we were so excited to come back home and come back to our department and do the thing that we really loved, and just, you know, working together as a team to make that happen.
Well, thank God for everybody's safety. We appreciate that. You guys did a fantastic job today. John, Jim, Gail, and Megan, we appreciate you. Thank you very much. With that, we come to the conclusion. I just wanted to remind everybody to log into our website to see the prior webinars and check this webinar out. And stay tuned for our next statement on the COVID safe checklist for your ASC. And I want to remind everybody that this is our 35th anniversary. Check your email for a special discount code for our True Virtual Experience, our annual meeting that's coming up in June 6th and 7th. With that, we'll conclude tonight's webinar. Thank you, everybody, again for joining us. Have a good night and God bless. Take care.
Thank you, everybody. Good night.
Good night.